I'm really excited to introduce Dr. Anne Wyllie. She's an epidemiologist and microbiologist who's a research scientist at the Yale School of Public Health. Her research focuses on diagnostic testing methodologies and statistical modeling for disease prediction. And Wikipedia and Twitter have informed me that she's earned the nickname the Spit Queen, as she's been harnessing and advocating for novel saliva-based testing strategies for over a decade now. Initially, she used those methods to detect and describe pneumococcus bacteria in community settings. And most recently, she's been leading efforts from Yale in validating and developing saliva-based SARS-CoV-2 diagnostics, such as Saliva Direct, which I think many in the group are familiar with. And so that's what we're going to be hearing about today, and we're really lucky to have her. So please take it away.
Thank you for having me. Let me just okay, so all of this started back in March 2020. I think, Yale had the foresight to set up the Yale Impact Biorepository, seeing that the pandemic was fast approaching from surrounding New York, Boston, making its way to New Haven. And so a lot of collaboration across Yale, the Yale School of Public Health, School of Medicine, Yale New Haven Hospital, went into setting up this biorepository with this idea of collecting a whole array of samples from COVID-19 inpatients so that we could better study SARS-CoV-2 and understand COVID-19 disease progression. Very early on, however, there were challenges every single day, and so many of these revolved around that gold standard nasopharyngeal swab. They're just hard to take, needing the trained healthcare workers to do so, being uncomfortable with that risk of patients sneezing or coughing. But what we were finding is that we were trying to ask healthcare workers to take a swab for diagnostics and then go in and take a second swab for our research purposes. So healthcare workers were not thrilled about the prospect of getting up close and personal for a second time with someone who might have this novel virus that we're still learning about. And understandably, patients were also, not feeling that great, either sick, miserable as it was, but also nervous about, again, potentially being infected with this novel virus and not incredibly willing to give second nasopharyngeal swabs. So based on my previous work with saliva, I did wonder whether saliva could play a role in improving just even sample collection. I'm not a virologist by any means. I had only done this in bacteria. I had no idea whether this would have worked for SARS-CoV-2. I guess everyone was a little bit desperate, as well as they were very supportive. And so agreed that we'd build up a sample set. We would have paired saliva samples with nasopharyngeal swabs and see how SARS-CoV-2 detection went. By the end of April 2020, we already had this data set where when we had paired nasopharyngeal swab samples and saliva samples from COVID-19 inpatients, and we were finding, if not as good as, but mostly better detection of SARS-CoV-2 RNA in COVID-19 inpatients. What's not shown here is that we were also sampling asymptomatic healthcare workers, and we actually getting them to do saliva and their self-administered nasopharyngeal swabs every couple of days. There were a number of instances on our very small, it was only an N of 9, so it's nothing that we've ever sort of, it was included in this publication, but never anything that we've sort of built too much of a story of because it was such small numbers. But even then, we were seeing earlier detection in our asymptomatic healthcare workers using saliva as a sample type as compared to the gold standard nasopharyngeal swab, which really gave us the motivation to look further into saliva as a sample type to aid many of the testing challenges that we were seeing. So what we have really identified first and foremost through all this is that saliva tests must be designed for saliva. So when talking about saliva, it is the collection of all oral fluid. It is not sputum. It is not mucus. There should be no sniffing of anything, coughing anything, bringing anything up. This also brings the risk of respiratory droplets. And if not properly collected, it can be difficult to work with. Saliva is also not a traditional diagnostic sample type, meaning that methods for swabs don't necessarily work on saliva. So early last year, we looked at the number of studies that had come out on saliva versus swab. in 2020, and actually found that in 69% of those, saliva had greater or similar sensitivity to the nasopharyngeal swab. And then, of course, we were seeing additional positive cases being detected in saliva that the nasopharyngeal swabs were missing. So looking at all of these studies and hearing what people were doing, seeing reports from others, a lot of the discrepancies which even continue to arise from comparison studies can be due to poor sample collection or poor methods for processing the samples. Again, recognizing that you wouldn't take a method that worked for swabs, apply it to blood, urine, any other sample type, and expect it to work, and then blame the sample. You would realize that that method just was not robust or suitable for working with this different clinical sample matrix. And I think there's a lot of that that's gone on in this in the last 2 years, which has really sort of clouded the picture on the usability of saliva. But if you can get a robust test, it can work really well. Importantly, though, is that good quality saliva samples can also be collected. So again, having patients be patient, thinking of favorite foods, not sniffing or coughing and not spitting due to that aerolization. So we first looked at this by taking 30 study participants, giving them a range of sort of saliva collection devices, and did an unobserved collection. So we gave them these kits with very little guidance. We had very little interaction with them, and just joined them on Zoom, switched off our cameras, our microphones, and just watched them do their collections. We then asked them a series of questions and also evaluated those samples when they came back to lab. So the major findings from this was that the participants did not think that they needed any help while collecting their sample, and they all felt pretty confident that they had collected their sample properly. Arriving back in the lab, these samples were of sufficient volume, easy to pipette, they were true saliva, they were mostly free of food particles, they weren't discolored, and we were getting sort of expected human RNase P values, so showing that there wasn't any sort of interference. And I just note that we have the preprint listed down here. I'm also very excited to say that this has actually finally been accepted for publication. We have a lot more data in here also for at-home collection now, but good to see that this can now actually be updated as of this week. We also saw, so recognizing that good saliva samples could be collected, we really recognized early on that there was going to be a need for frequent repeat testing, and for that, testing had to be affordable, it had to be sustainable. And so when we looked at the saliva collection devices that were on the market, this is actually more about sort of April, May, June 2020, these devices, they ranged in price anywhere from $28 down to about $7, which if you're thinking about setting up a mass testing program, will just quickly max out the funds that you have for that very early on. Whereas if you take very simple laboratory plastic tubes, these are in the range of cents to adding a straw, a little bit more. And the major difference between these is these are simple laboratory plastic tubes, and these all are filled with buffers, reagents, many said to stabilize RNA. So recognizing that we wanted to have sustainable testing programs, we wanted to see were these stabilizing buffers actually needed. So we took raw saliva samples from the COVID-19 inpatients, and we tested them when we received them in lab. We also stored them at -80 and did a freeze-thaw cycle on them. We left them at room temperature for 5 days or 30 degrees Celsius for 3 days, and then tested them. And so each sample and its aliquots are joined by the dotted line, and we saw pretty stable detection of SARS-CoV-2 RNA in each of those settings over those different periods and temperatures. We also did this in a much more haphazard way, recognizing that we were in the middle of a pandemic, and as we had excess sample, it was about, should we leave one here? Should we leave one here? When do we have room to test it on another plate? So it wasn't beautifully designed, but we got some samples, out to 21 days, 25 days even at room temperature, just sitting on the bench in their raw saliva sealed container, that we saw sort of essentially no change in SARS-CoV-2 RNA detection. So really highlighting to us is that these expensive collection devices were not necessary. So armed with that knowledge, and then really wanting to make a test that was accessible. So through, these first early months of the pandemic, it was understandably those who had symptoms who could get tested, But otherwise, it was those who could afford to get tested, with many tests out there, in the range of $100, $150. It just really, making testing inaccessible to many. So we recognized that RNA extraction was the most expensive and time-consuming step of the process. It was also very subject to some sort of supply chain constraints or disruptions. So we wanted to see if we could remove RNA extraction and come up with this approach where instead we take a very simple passive drool sample, mix it with proteinase K just to help break up the sample if needed, and activate the proteinase K for 5 minutes at 95 degrees Celsius, and then test in dual-plex RT-qPCR for SARS-CoV-2 and the human RNase P as our sample quality control. So we used the CDC's N1 since it was already so widely used throughout the country at that time. And we had looked at doing more of a multiplex to begin with, using either N2 or E in combination with N1. But, developing this sort of April, May 2020, we just found that whenever any additional targets we added affected the sensitivity of the qPCR assay. And we just wanted to make sure that it was as sensitive as possible at that time, because we did not know what 38 CT or 39 CT meant. Obviously smaller amounts of viral load, but we didn't understand infectivity at that time and risk. And so we just really wanted to minimize our chances of false negatives as much as possible. So this gave us a test that was non-invasive, less expensive, and can circumvent supply chain disruptions. So importantly, for each step of the process, we validated different instruments and reagents to get around any of those supply chain disruptions, to also help have competition on the IFU, to help labs utilize their existing supply chains, maybe their customer service relations they already have, to get the best price possible. And also on the PCR instrumentation, that labs could utilize what they already had. We didn't want labs to be having to purchase new PCRs. Any investment that they were going to have to make to set up testing would understandably get passed off to the patients, and that's what we wanted to minimize. So doing this, we got the cost of the test, just reagents, down to about $1 per sample. Many labs have reported to us their actual running costs are anywhere between sort of $6 and $10, maybe $6 and $15, depending on the rents, taxes, insurance, staff costs, investments that they put up originally through all this. But it has made a very cheap test option for them. We were able to also maintain that level of sensitivity. So our official sensitivity is our LOD is recorded at 12 copies per microliter. That's the least sensitive combination we have with the various different reagents and instruments, just showing an example of that. We can actually get down to 1.5 copies per microliter. But I think what we're most proud to see is that actually when we did the FDA's blinded panel that they sent out, is that we actually have detection equal or better than 38% of the other EUA tests out there, but also including the CDC's own RT-qPCR assay. So our LOD with our least sensitive combination is the same as the CDC's own assay that uses RNA extraction. So we got around the RNA extraction and maintained that level of sensitivity. So with all this, we received emergency use authorization on August 15th, 2020. It was stated to be the most unique EUA that the FDA has issued to date, in that we are an open source EUA, and that we've also been issued an EUA as a manufacturer, even though we don't make anything, we don't sell anything. All we're able to do, or what we wanted to do, was be able to give labs our protocol and allow them to go directly to their suppliers, get the best prices as possible, and just be able to test under our EUA and set up testing more quickly in their local communities, having done all the upfront validation work ourselves, and knowing that they could test under an EUA test. So we have now designated, actually this number updated last night, to 173 labs in 41 states across the country. And I think what was most, unexpected for me, but been really inspiring, is that, we made a test, we rolled it out, but we've had this really collaborative and growing network sort of grow up around the test itself. So we have an active Google group We have a Gmail that our labs can reach out at any time on. And, you know, at first I was hosting calls twice a week with labs to sort of troubleshoot, talk them through it, update on what we were seeing. That dropped to once per week, and now we've dropped it to fortnightly calls, but we still have anywhere from 30 to 50 participants joining every fortnight just to discuss even like successes, challenges, updates. So it's been really nice to see this network across the country of these diagnostic labs. Based on the labs as well is that we've also continued to expand our protocol. So across the top in grey is where our protocol started, a few reagents, 3 instruments, and our labelling meant that collection had to be observed by a healthcare provider. But since then, we have validated up to, I think there's 23 qPCR instruments, again, wanting labs to be able to use what they already have. And we've also expanded the labeling. So we have full asymptomatic labeling, but you can still have your sample collected by a healthcare provider. We also did like a little training PowerPoint deck. So you can also just give that to anyone, and then they can be a trained individual if you want to have supervised collection. We also have unsupervised collection, at-home collection, pooled testing, and also authorization for at-home testing for under 18-year-olds as well. So again, many of these have been in response to what labs needed. And once we make these updates, they automatically apply to all labs across the network. We've also introduced 2 additional workflows, again, in response to the lab needs. So we learned that there are very many different EHS requirements around the country, and that in a number of settings, labs were required to heat their samples before opening them, and that wasn't on our EUA, so technically they couldn't do that. So we talked to them, we heard what they needed. Say, for example, there are a couple of labs who were already looking at the 95 degrees for 30 minutes. They wanted to do that. From the literature, we also saw that these other times and temperatures were also sufficient for inactivating SARS-CoV-2. So we also put those in there so that labs would have options on what they could use. And we also found that whether you use proteinase K or not, you get near identical detection. So across all of these 3 workflows, with whichever combination you use, we have essentially the same LOD across them all. And at the same time, we're giving opportunities for safer sample handling. And also we've heard that that heat can also improve viscosity for easier sample pipetting as well. So I mentioned that we had also introduced pooling. I just wanted to very briefly touch on that. We can also pool up to 5 samples, but in the spirit of Saliva Direct, we also validated 2 different workflows. We actually, I think, started by testing about 5 or 6 of the different workflows and combinations. But again, we just wanted to give labs that opportunity. If they needed to do heat pre-treatment, they can. If they don't need to, they don't want to, they don't have to. So really, this protocol means that all throughout, labs can really pick and choose their own adventure with their instruments, their workflows, their pooling, their reagents. So just in summary of just Saliva Direct itself, again, this is not a test kit. There's no commercialization. We make no profit. All we simply do is authorize CLIA certified labs to test under our EUA. And that this was, again, really to reduce that implementation time that labs had to take to implement testing and to increase the number of tests in the local community. And we've really emphasized through all this is that wanting to have that local community testing, because that can get you faster test turnaround time. A lot of our labs report in 4 to 6 hours, many within 12, and the majority within 24 hours. Also, if you're testing in your local community, you can get that local buy-in. You know, you're supporting the local economy, or you have the relationships with the school or the workplace down the road who you're testing. We've also seen that we've had a very low invalid test rate and a low sample rejection rate. Again, really highlighting that, you know, if you have good collection instructions and sending that out there, you can receive samples that are of adequate quality for testing. And I think we're up to about over 4 million tests now. The numbers is just from our last reporting survey are just sort of coming through at the moment. So it's been great to see that it's been used, you know, hospitals, schools, universities, companies, sports leagues. And thinking now where to next and going forward, one of the things that we already saw in December was the suitability of saliva for Omicron detection, and how we must continue to think or adapt our testing programs in response to potential new variants as they emerge. So as Omicron emerged, you know, the early reports were that there was 70 times increased replication capacity in the bronchial tissue. There was that shift in symptom profile with more sore throats, less loss of smells, and being highly transmissible. And through a workplace employee testing program of one of our collaborators, they recognized very early on in December where the employees who they were testing, they did had their work without masks. It was a very high risk situation. So everyone was tested at night by a saliva PCR test so that the result would be available in the morning. But as they came together in the morning, they would also do a rapid antigen test, you know, just in case, that extra sort of security measure of, you know, any last minute infection that you could catch. And what we started to see was that saliva PCR tests were coming back with a CT value of anywhere between 18 to 23, so incredibly high viral loads. But the antigen tests weren't testing positive till 3 days later, sometimes 4 or 5 days later. And, you know, there was being transmission observed during this time. And we were starting to hear that this was also being seen by other collaborators across the US. And in the end, South Africa also came out to say that they found saliva to also be more sensitive than the mid-turbinate swabs. So, you know, there have been some really great studies from Caltech, UIUC, University of Maryland, who have shown that saliva can be more sensitive early on in infection anyway. But, you know, this 3 days and the nasal swabs just not detecting the virus at all, and that it was a very oral infection, you know, it just really highlighted that, you know, we do need to keep these testing programs in mind and, you know, adapt our responses in the interest of public health if we do see, you know, shifts in these infections, and using the right test at the right time. So where to next for Saliva Direct at the moment? We're just continuing to monitor that assay, but we're also working to expand it further. You know, especially when Omicron came out, you know, we had to do a whole lot of in silico and in vitro testing to show that we could still detect despite Omicron's mutations. So you know, a lot of labs often ask us about just having an additional target in there. You know, we keep close watch on N1 and making sure that it is still going to be detected, but having that sort of safety net of another target in there would just help us there. But it can also help potentially, you know, give a bit of a warning if any variants emerge, and we also can do, you know, monitor for any dropout of any target as well. We're also looking to expand for the likes of influenza, RSV as well. And we're also looking to just really formalize the network to help continue research-driven collaboration and have this network available for rapid public health response. And just a couple of images from the lab. We're also looking to expand international collaboration. So Saliva Direct has already been independently validated in at least 12 countries. We generally learn about this from publications that come out or news articles, which is always really exciting to find, especially since I should also point out that, yes, I've missed New Zealand off my own map. But they were one of the ones that I found out that they had validated Saliva Direct just through news articles. So that was really cool to see. But all of these other points on this map to the right are other countries that have validated some sort of saliva-based method for SARS-CoV-2 detection during the last couple of years. But saliva has, of course, has also been validated in other countries for other sort of tests, such as for norovirus. HIV is a very popular one. Australia has been exploring HPV. So there's a lot of potential for saliva in other diagnostics as well. So just to summarize again, is that, again, saliva collection of all oral fluids, and doing so can help reduce the risk or burden to healthcare workers. It can be more sensitive than nasal swabs, especially early in infection, and that the benefits of saliva could prove even greater in low resol settings, meaning that you don't need cold chain transport, you don't need expensive devices, and that, you know, we do need to be thinking about inexpensive, simple, scalable testing to be available, and how we're going to sort of move forward with screening and surveillance, not necessarily just diagnostic testing. So that's it. So thank you very much.
Thank you so much for the really nice talk and for all of the incredible work you've done during the pandemic. I think Lauren said that her computer crashed, so she sends her apologies. I don't know if she's still attempting to reconnect, but it seems like she's having some issues. So I'll start with one question, which, one of the issues I see kind of moving forward is that I think like public health resources for testing are likely to drop dramatically following this Omicron surge. It's likely there will be another surge at some point in time in the future, and I feel like we'll be in the same place where like kind of tests are limited at some point. And I wonder if Saliva Direct has any benefits for those kind of situations to kind of rapidly decompress and then also increase availability. Or if those are kind of more logistical issues with just sample collection that is maybe Saliva Direct doesn't help with.
No, so that's exactly what we're in discussions with our lab network now, because of course many are facing that decrease in test demand, and how is funding of testing going to look going forward. But what's great about Saliva Direct is, first of all, just bypassing RNA extraction. So it means that labs are really able to keep their other diagnostic testing workflows going. So, of course, so many say who don't use Saliva Direct, any other swab-based methods, even at some of the other saliva-based methods, if they use RNA extraction, you're typically using instrumentation that you would use for your other diagnostic tests. So almost having something like Saliva Direct even in your back pocket, which means that you can go back to your standard diagnostic testing. And if demand starts to increase again, you can still then keep your normal workflows going, but sort of run Saliva Direct in parallel much more easily, because you're not using the same instrumentation necessarily. It's streamlined, it's quick, it's easy. The materials are simple. You don't just need to have like a kit of specialized proprietary materials sitting there. You can probably even start adapting from your other just doing heat and having a normal PCR master mix. You can sort of go ahead with this. So it's very easy to scale back up in times of need, and being low cost and easy, it's something that I hope that can be used in a number of settings to just also keep some level of community surveillance. I mean, there are so many schools around the country who are so used to giving saliva samples now and having, their weekly PCR tests that, if there are a select number of schools who would be willing to continue to test. I mean, a school provides an early warning system for its community. If a kid has COVID, its family likely does. Does that come from a workplace down the road kind of thing? Or is that kid taking it home to their family? That this could be how we continue just to measure community surveillance a little bit easier.
Thank you. Any questions from the group?
You gave a list of the different diseases that saliva can detect. Does it also work with flu? I didn't see it in the list.
Yeah, it does. So, we actually reached out to Calvin Toe. So Calvin Toe came out with a paper very early on in 2020, I think February 2020, and I think they only had about 12 SARS-CoV-2 positive individuals, but they were the first to sort of publish on saliva. And we reached out and had a conversation with him, and he said that the reason why they were so well positioned for saliva and SARS-CoV-2 early in the pandemic is that he had just finished a large research study at the end of 2019 using saliva for flu detection. And there had been some older studies that are in the literature as well. So we do think we expect it to work, but the big challenge at the moment is finding positive samples, especially if you need to get them paired with like the gold standard nasopharyngeal swab. So we're working with collaborators around the country to see, I've got even like an IRB in place where it will cover any of our Saliva Direct labs, any of our collaborators, we can just sign them on to the IRB. But if it means that, if people start reporting for viral panel testing, they can either just give a saliva sample at the same time, and based on that viral panel result, is it of interest for us or not? Can it come here and we can study it? Or do we just, again, it's such a low cost sample to collect that even if we build some of these up, it's not a huge ask. We're also looking at RSV, and it's only, again, RSV samples, flu samples, really hard to get, great for public health, difficult for public health research. So we actually have a collaborator in the Netherlands who sent us some paired nasopharyngeal swab and saliva samples from RSV positive infants in the NICU. And we had near identical detection in saliva as what they had on the nasopharyngeal swab. So again, it's only 5 samples. We did a mini stability study on one of them, but again, the stability, we also thought, SARS-CoV-2 RNA is so stable in saliva, but is this going to be the same for other viruses? And of course, that's going to impact how you can collect and how you test. But the sample that we tested for RSV is also showing to be very stable, again, as an N of 1. But we are continuing to collect samples and hope that, flu will follow suit, and that we'll get more eventually.
Interesting. And is there any way to differentiate between strains from saliva test, or is that something that is not doable?
For SARS-CoV-2 or for
well, both actually, flu
yes.
and.
So there are specific targets already for PCR for flu A and flu B that the CDC. So again, thinking about adapting Saliva Direct, we're just going to go. Our whole thing has been to go the path of least resistance. So it would be taking the CDC's primer probe regions for flu A and flu B. Flu B is going to probably be harder to validate just because it's so much more rare or harder to get those samples. So we're either thinking of putting them into a single channel for now. So you get, if you had flu, SARS-CoV-2 and RSV, maybe even strep and a PCR, okay, you get pinged for flu. You might have to do a reflex test, but it's a way of sort of preserving the channels that you have in PCR. And at least then you can more quickly detect and follow up from that. And then for SARS-CoV-2, you can do sort of variant panels as well. So, something similar to the attack path where they saw S gene target failure, you could choose some different PCR targets, and depending on what's positive and what's negative, sort of get an indication for what variant you're working with.
Cool. Thank you.
So unfortunately, I think I missed like the heart of your talk because my computer crashed, which never happens, but it happened. I think it didn't like going to campus yesterday. Anyway, so at risk of like asking you something you've already explained, I don't know if you were kind of talking about, individual saliva sampling or pooled sampling, but I guess that just sort of to help me understand where you think things are heading, like imagine 2 years from now, it's winter, we're in flu season, maybe also COVID season. What do you see as like the best case scenario? How are saliva tests being used either clinically or in daily life or in schools? What's your vision for the future?
Yeah, so I am still a big advocate for just community surveillance and, whether we can keep workplaces engaged, schools engaged, how many have seen the benefits of early detection. So, we pulled Saliva Direct up to 5 samples. We didn't go higher because it's already such a simple, easy, cheap test that a lot of the labs didn't see too much of a need. But there's other labs like Miramis Labs in Brooklyn who are already pooling 2024 samples of saliva. But, I think what I really hope we can do is sort of more of this forecasting through the actual, so many of our case counts for flu and RSV are when they hit the hospitals, and it's then that that it's in communities, but you could already have a 2-week lead up to that in the community. If you've got a daycare and be like, hey guys, RSV starting to spread, flu starting to spread. We're used to wearing masks now some of us are okay about wearing masks still, but, maybe that's where, if I hear that flu is going up in my local area, I'm probably more likely to start wearing a mask at the gym if I stop wearing a mask at the gym. That just little things like that so that we can better understand how these viruses are moving in our community and how we can take that knowledge to help just improve the health of our communities.
Yeah, thanks for that. I think we agree. Oh, I don't know. I agree. I think that, I'm whatever kind of surveillance data we can get, the more timely and the more broad, the better, as long as we can train the public to respond appropriately. right?
Exactly. And that's exactly why I'd like to keep, we're hoping to really keep our network engaged to some extent. And because I was like, we've got 173 labs, 41 states across the country, that, even setting some of these up and just hearing, even having them, I mean, I know that all of these labs are supposed to be reporting to their local health departments, but how many of those actually, when does that, information come in? For months now, maybe longer, I've been wanting to have like a dashboard of saliva direct tests, because even if you saw an increase in demand for saliva direct test, but the case count was staying low, or test positivity was staying low, you could maybe think that there's something else going on, whether it's just a different cold that's circulating, until we can multiplex, is it flu, is it something else that's driving people to increase testing as well. And even knowing that could be like, hey, something's going on and moving throughout your community, how do you want to respond to this?
Yeah, that's really interesting. So do you work at all with public health departments and trying to sort of help them think about how to integrate this kind of data into their surveillance efforts and response efforts?
That's interesting. We haven't yet, and I think that's because we don't have we have to do regulatory reporting for the FDA, but I think until we get more of a sort of real-time data reporting, or having just to reach out to the departments of health and seeing what they might be interested in and what they're wanting to feed back. But it's not something that we've had too much bandwidth for yet, or I guess knowing the right way to go about that.
Yeah. Are you aware of, or do you have any connection to the Pandemic Prevention Institute that's funded by Rockefeller and run by Rick Bright?
Yeah, so we actually we've had some amazing support from the Rockefeller Foundation, but it was through more their sort of just the testing group, and so they supported salaries for some of our staff, and we did some playbooks in association with them. Sam Scarpino was here in New Haven a little while ago and met with him, and so I followed up with him an email, because I was like, here you all are wanting to do pandemic preparedness and do forecasting, and I'm like, we've got this network of labs who's incredibly collaborative, like maybe there should be something there. But to date I have not heard back from them, but I should probably follow up with them.
I mean, they're from what I can tell, they are trying to sort of figure out what their foci are going to be around revolutionizing data collection for early warning, et cetera. And it seems like what you're doing would fit right into, where they're headed. So yeah, next time I talk to Sam, I'll mention it as well, but certainly I think there might be a great match there.
Thank you. Yeah, no, I mean, yeah, I definitely agree. And especially just the nature of what we're doing as well. I think, well, obviously Rockefeller, the work that we've already done, our mission sort of falls quite in line with that of Rockefeller, or just, trying to low cost testing and for public health. So I think it's, a nice potential collaboration.
Yeah, and you hinted at this in your answer to my question, but are you, and I didn't again miss part of your talk, but are you moving towards the saliva test, really testing for all known causes of viral causes of respiratory illness? All is probably not on our radar so far, but definitely flu, RSV, maybe strep. So the main ones of, do you need symptom, do you need early treatment? Is this going to affect, your risks to others, and how you're going to sort of carry, your, what the risk you pose to others. Just because, I mean, I know that there's, there are great respiratory panels out there that can do a whole range of viruses in one. But again, it comes back that our test is just so cheap. And so I didn't mention it, but I had it on one of the slides, is that one of the things I'm excited about is also on the academia, my research hat on, is just, what we can also just learn about community transmission on the research side of things. But the idea that, again, we could still be testing a school, a workplace for a few dollars using this versus getting respiratory panels, which are going to cost a lot more and be a lot more involved. So definitely, whether it's a panel or two in the end for some different sort of markers. But yeah, I mean, we've also thrown things around like HPV or TB, but first and foremost is going to be other respiratory viruses. So that's interesting. I wonder if, I mean, you may know the answer to this. So if you're covering flu, COVID, RSV, and strep, and I don't know if there's any others, like, is it pretty clear that if somebody goes in with respiratory symptoms and is negative for those four, it's very likely they're going to have a mild course of illness that doesn't require treatment? Like, have you, like, has there been sort of a classification analysis? Like, if you want to kind of separate things you want to test for and know what they are because they need special treatment or they need to be isolated or whatever it is so that others don't get it, versus the ones that, yeah, it'd be nice to know what they had, but it's not clinically relevant. Like, do you think that the four you mentioned are a good sort of, are the ones that we need to worry about and respond to? And there may be a few things in the mix, but most of anyone else who comes in and turns out negative for all those probably has something fairly mild.
Yeah, exactly. They're more likely to have like a rhinovirus or a coronavirus, which of course, they can expand into something else. Not to say that, they don't need, but, they're sort of the things that sort of move through the population and cause, less, have less impact on quality of life or, isolation or, risk of like more severe disease.
Yeah. So, but is that actually grounded in like some study that's looked at kind of outcomes in relationship to positivity for different sorts of viruses, or?
Nothing that we've like done intensive analyses on ourselves. It's sort of just knowing, I guess it's one of those things, just like being around the hospitals, the clinicians, what people sort of explore, what they want to know. Exactly, if you get early detection of SARS-CoV-2 or flu, is it going to be one of the SARS-CoV-2 treatments or, a Tamiflu treatment kind of thing, or just even RSV, it's just more of a warning sign as well, just to others that it's in the community and, looking after kids.
Yeah, it might be interesting just to look at, like what is the expected duration and severity of illness for people who test negative for all four versus, having one of those. Just.
And I mean, that's the other thing. I mean, like, going back to the research is that some of these swabs that we have from the RSV cohort, some of them are rhinovirus, enterovirus, coronaviruses. So we are going to validate those as well. And whether that ever goes diagnostic, because there's only so much we can do with a very small the PCR test that we have. But again, looking at it from the research side. So in the end, if we're collecting research samples from daycare centers and I collect samples also from healthy elderly in the community. But the same thing, if you've got a single saliva sample and just knowing how much, it is so much cheaper to collect than swabs and so much cheaper to process than many other tests, that we can then also just start studying detection of how common is rhinovirus or human metapneumovirus out there that doesn't usually get studied or much attention, so that we can also understand those things more as well.
Yeah, very interesting. Do you work at all with Alison Galvani? I missed if there's any connection there.
No, I don't actually. I mean, she's in the department, but no, we're actually like in different buildings even, so no, there's not much overlap.
Okay, we've collaborated for years with their group, and including actually, we share a grant from NIH that's actually focused on trying to model the co-circulation dynamics of different. This is pre-COVID, of different respiratory viruses, and specifically using electronic health record data for people who come in with complaints related to asthma and COPD as a proxy for, but anyway, there's, I'll share a paper and maybe start a conversation.
Yeah, no, that'd be great, because of course my other real world focus is Streptococcus pneumoniae. So of course, pneumococcus and the interaction with different viruses. And, the idea has been really interesting that pneumococcal carriage seems to have persisted in adults and children throughout the pandemic, when we thought mitigation measures would stop that. But you see so much less pneumococcal disease, because so much pneumococcal disease is influenced by co-infection with viruses. And because those viruses aren't there, pneumococcal bacteria has persisted, but without the level of disease that's,
That's so interesting. So is, like, do you have a sense, can you explain a little bit how that works mechanistically? Like what happens when somebody's carrying and then they get an infection? Is there some part that like clogs up and allows the bacteria to really grow, or?
There's been some studies investigating whether RSV even has almost like a binding capacity to pneumococcus or has an ability to help draw pneumococcus through epithelial layers with it.
Oh, interesting.
And then I believe it's just I just need to double check this, but I believe with influenza, it's about when influenza sets up its response, it's more the immune response and everything else that's happening, that it creates an environment that allows the pneumococcus to proliferate. And then of course you're having all the immune reaction, just like, leaky epithelial at that stage, that's then going on to cause, the damage.
That's really interesting.
Yeah.
Are there published studies on what you just described earlier about pneumococcal carriage rising while pneumococcal diseases fall in?
Yeah, there are. So far, there's a study from Israel and from Belgium, and then the knowledge of that in adults and elderly is from the data that we're trying to, we're finalizing from our first study season ourselves here in New Haven. So,
oh, great. Well, we'd love to have you come back and talk about some of that. That's fascinating.